All right, everybody. So welcome back. We're excited to continue with today's session, and as we move on to this afternoon session, please remember to use the chat function or raise your hand if you have any questions during the Q&A portion. And so, without further ado, let's get started. So, it's my pleasure to introduce our next presenter, Dr. Sanjay Murthy. Sanjay is a gastroenterologist at the Ottawa Hospital IBD Center, Associate Professor of Medicine at the University of Ottawa, and Scientist at the Ottawa Hospital Research Institute. Sanjay will be presenting a superiority trial comparing the diagnosis rate of colorectal neoplasia and colonoscopy burden between a model-guided strategy and a traditional guided strategy for colonoscopy timing in inflammatory bowel disease, the dynamic IBD trial. And so please join me in welcoming Dr. Sanjay Murthy.
Thanks, Jan. Happy to be here. I can obviously skip my title slide. Um, I don't see the audience, but for all who are there, thank you for coming. So my research question really is stated in the title itself, but essentially what I want to know is whether a dynamic multi-factor prediction model applied at regular intervals in practice to guide colonoscopy prioritization can outperform a traditional model, which is basically expert opinion guided prioritization based on single risk factors that are described in the literature, with the primary outcome being the ability to detect advanced colorectal neoplasms, and a secondary important outcome being overall colonoscopy burden in the IBD population. So just as a bit of background, inflammatory bowel disease, which captures Crohn's disease and ulcerative colitis, um, as suggests, affects the bowels with chronic inflammation, and that tends to drive colon cancer risk. And IBD patients in recent large series have shown about a 1.5 to 2-fold increased risk of colorectal cancer as compared to age and sex matched members of the general population. Our current and only strategy for trying to minimize this risk is intensive colonoscopy surveillance, starting at about 8 to 10 years following disease diagnosis, irrespective of patient age. That's largely based on epidemiologic data of when risk starts to increase in this population relative to background controls. And at present, the surveillance methodology that we use is fairly archaic. It's really based on expert opinion. It's guided by a handful of risk factors, most of which are IBD specific risk factors, to really categorize people into high, medium, and low risk, and standardize their surveillance intervals to 1, 3, and 5 year intervals, respectively. And that sort of surveillance paradigm just carries on for the rest of an individual's life. There is some, physician interpretation of what that may lead to slight extension or shortening of intervals at times, but for the most part, it's fairly fixed. And guidelines have adopted this strategy, throughout the world. But there's actually no evidence that this strategy works or is the best strategy. It's just what's been done. And what we know is that, well, first of all, patients are typically diagnosed with IBD at a young age, often even before age 10, but generally before age 25. So when you enroll them in a intensive colonoscopy surveillance program, it leads to a huge colonoscopy burden, upwards of 50 colonoscopies for some individuals who are diagnosed at a young age if they're undergoing annual or biannual surveillance. These high demands for colonoscopy, in combination with the high demands for everybody else outside of IBD, leads to longer wait times for high-risk patients who might stand to benefit with earlier procedures. And despite intensive surveillance, more than 50% of colon cancers in IBD patients arise after diagnosis. So it means that there's a bit of a disconnect. Even though we are intending to surveil these patients intensively, we're either not doing a very good job, or we're missing some individuals who have important risk factors that we may not even be recognizing. At the same time, across all colonoscopies performed in IBD patients, more than 85% of them don't detect any neoplasia at all, even the earliest precursor lesions. So the current methodology essentially leads to underdetection and overprotection, if you will. And so it's not a very scientific strategy. So my proposed solution for that is that we change the paradigm, or at least test changing the paradigm, from this fixed intervals single risk factor strategy to more dynamic intervals using multiple, both traditional and non-traditional risk factors and protective factors. There are many recognized risk factors and protective factors in the general population that we don't actually even adopt in the IBD world because they get trumped by disease-specific risk factors. But those factors still probably play a role. They just don't. We don't have any mathematical way of incorporating. So in order to do this, the first stage, which is where the study is currently at, is to derive and validate multivariable models that predict colorectal neoplasia risk that can then be applied to the point of care at the point of care to prioritize colonoscopy. So these need to be models that are based on information that's readily available to clinicians and that they could harness in short order with patients sitting in front of them. If and when such models are developed and show reasonable performance, the next stage would be to test using such models in an algorithmic fashion to determine whether application of these intervals regularly to guide whether or not an individual should or should not undergo colonoscopy at that point in time can do better than simply fixing intervals for individuals based on single risk factors. And ultimately, if that proves to be useful, we would then enter a more implementation phase, wherein we would hypothetically develop support tools and guidance on decision making, and possibly even test implementation strategies to optimize usage. So the proposed trial would be a parallel group superiority, randomized controlled trial. The population would be individuals with colorectal IBD, so IBD having historically affected 1/3 or more of the colorectum, having been diagnosed at least 8 years in the past, and because that is just the accepted time frame for starting. And also individuals for at least 1 year post colonoscopy, because the earliest surveillance intervals right now are 1 year, which itself is quite intensive. It would be hard to justify recruiting individuals at the point where they've just had a colonoscopy 3 months earlier, only to be told that they need another one in 3 months. So on an ongoing basis, the minimum time interval between scopes would be a year, even during the trial, but at the same time, recruiting patients at the point where they're at least 1 year out from their last colonoscopy would make good sense. The intervention, so what we're trying to test here is a model of care, not colonoscopy itself. That's a proven tool that can prevent colorectal cancer, but we're testing how colonoscopy is applied. So in the intervention arm, this would be the timing of colonoscopy would be guided by a predictive model in real time to decide whether or not an individual undergoes colonoscopy in the next short order, 3 to 6 months. And the control would be a conventional algorithm where individuals are deemed to need a colonoscopy in 1, 3, or 5 years based on their current risk factors. The follow-up would be up to 5 years. So 5 years in everybody, but some individuals may leave the cohort, go to other practices, other provinces or countries. So they'd be followed up to the point where they left. The setting would be in Canadian academic centers and realistically gastroenterologists who have research coordinator support, because quite honestly, these are the only individuals who are likely to participate in a complex trial. So by default, that would be the investigator and setting population. Randomization would be a 1-to-1 by permuted blocks, varying block sizes of between 4 and 8, and stratified most importantly by investigator, because the biggest differentiation in terms of how surveillance is followed will be based on individual investigators' practices and styles, but also stratifying by one or more currently recognized major IBD related colorectal cancer risk factor, so that we ensure that both high risk and low risk individuals are randomized in both arms. We'll get into this a bit more, but the procedure allocation throughout the course of the trial in this case would be not so pragmatic. It would be in my current vision would be coordinator led, The reason being, this is a fairly complex uh, algorithm that's being applied to practice. There's going to be some skepticism as to whether it's necessary or useful. So, for something like this, I feel like it has to meet proof of principle before it would be implemented fairly. And if just left to pragmatic implementation, the course of routine practice may fail before it starts. So this would be a sort of a coordinator-led implementation of this, where research, where the decision making would be taken out of the hands of physicians for routine surveillance, and coordinators would instruct investigators as to when a patient's colonoscopy is due. And the data collection would essentially be largely through electronic medical records, and through patient and physician surveys, actually, for secondary outcomes. The primary outcome intended for the trial would be the ability to detect advanced colorectal neoplasia, so high risk, and that would be based on a consensus definition of what we consider to be very high risk. Would include colorectal cancer, high-grade dysplasia, multifocal dysplasia, advanced histologic types of dysplasia, etc. There's a short list of high-risk features. And our current strategy, which surveils everybody at least every 5 years, so it's 1, 3, 5 year intervals, is intended to detect high-risk neoplasia by at least 5 years. What would be very useful to demonstrate by this kind of strategy is that when you apply a more robust strategy using multiple risk factors and protective factors, that you can identify these high-risk neoplasms earlier overall in the patient population. So the primary outcome that I set would be the proportion of participants with high-risk neoplasia identified within 3 years of randomization. But a key important secondary outcome, so that's a more of a healthcare focused outcome. A key important secondary outcome, which is more of a health system outcome, would be the colonoscopy burden, which I would ideally measure as mean number of colonoscopies per participant over 5 years. So we sort of reviewed at the beginning that like there's two shortcomings of our current approach. One is that some individuals still develop cancer despite intensive surveillance, and for clinicians, that's always the most, not missing high risk lesions would always be the most important facet of any strategy. But a second limitation is that many individuals undergo colonoscopy unnecessarily. And so a important secondary endpoint would really be trying to reduce the colonoscopy burden. So even if the detection rate of high-risk neoplasms was equivalent in the two arms or similar, if you could substantially reduce the total number of colonoscopies being performed with a model-guided strategy, that also would be relevant. Other secondary outcomes would be fidelity, so adherence to the prescribed algorithm. So this is a bit artificial in the sense that the implementation would not be pragmatic, would not be necessarily in physicians' hands, but physicians will have the flexibility to opt in or out in real time if they decide that there are some concerns and that they think that the patient needs a colonoscopy for whatever reason. They can depart from the trial specifics and perform that at their will. So there will be some interest to know, in this, even in this kind of fixed implementation strategy, what was the fidelity to the prescribed algorithm. We can measure that on a per participant and per procedure basis. But of course, that wouldn't necessarily reflect what would happen in real clinical practice when physicians themselves would be responsible for making these decisions. It would just sort of be a cursory look. But certainly we would perform extensive physician and patient surveys to try to identify barriers to implementation of such a strategy in clinical practice, and also to sort of gauge what their satisfaction was with either strategy in the course of the trial. So this is sort of a schematic as to what the trial would look like. So on the far left is our eligible population, individuals with colorectal IBD of more than 8 years, having being at least 1 year past their last colonoscopy, and they would be randomized by investigator and stratified by one or more risk factors into one of two strategies. The top strategy being the intervention, which is a model-based algorithm, and the bottom strategy being standard of care. In the top model, this is a putative algorithm. It may need refinement, but just to give an example, the vision for this would be a sequential modeling strategy where initially a multivariable model is applied to identify individuals who are at high risk of having colorectal cancer at that time, um, with high sensitivity. And then anybody falling below a cut point would be run through a second multivariable model to identify those being at high risk of having any residual neoplastic lesions, whether they be colorectal cancer or precursor lesions. So those with, at high risk of high risk colorectal neoplasia would ideally undergo colonoscopy very early within 3 to 6 months. Those deemed to be at lower risk of that, who then are remodeled and deemed to be at high risk of potentially having any neoplasia, low or high risk, an investigator may choose to stratify that individual to colonoscopy within 1 to 3 years. So a little bit more flexibility there and further guided by other risk factors. Whereas individuals falling below probability cut point in both of these models would then be deferred. And then this modeling strategy would then be applied at every touch point. So every clinic visit and at least 1 year following every colonoscopy, but applied in the course of routine care. So not specialized visits or cold calls to determine risk, but in the course of routine care, when a physician would normally be making that decision, that is the point in time when a coordinator would also be making that decision as to whether or not this individual should be undergoing colonoscopy in short order or could be deferred. And that process would continue on a regular basis until 5 years, which is when we would assess outcomes. And in real practice, we would assume that by that point in time, anybody who has not undergone a colonoscopy and continues to be deemed to be at low risk by the multivariable model would then continue to be deferred. So this is the potential colonoscopy savings. And we would identify what proportion of the population had high risk neoplasia within 5 years. For the purposes of the trial, everybody would have a colonoscopy at 5 years because we need to have a clear denominator for neoplastic lesions. But the colonoscopy burden assessment would be based on what the model predicted they would need. So that's a putative model guided strategy that then needs to be vetted and discussed in more detail with colleagues and the steering committee. By contrast, the standard of care would be a low risk, medium risk, and high risk stratification based on currently recognized major risk factors. And since it's been more than a year since their last colonoscopy, if they were in a high risk group, they would go colonoscopy right away, as if it was sort of a 1 year time frame. If they were moderate risk, they would go colonoscopy 2 to 3 years from their last colonoscopy, and if there was at the very low risk, 4 to 5 years from their last colonoscopy. And then the ultimate outcomes would be assessed at the end of 5 years. So when thinking about this, about this trial design, I think it's got some pragmatic components, but it also has some explanatory components. I wouldn't necessarily call this entirely pragmatic. There are some pragmatic elements in that, individuals are being recruited in the course of routine clinical practice based on, needing surveillance regardless. So it's the patient population that we would normally be enrolling in surveillance. Physicians, aside from the intervention itself, will be given flexibility to practice as per standard of care. That would mean that if they felt that an ad hoc colonoscopy was necessary, they would have the capacity to do so. So this wouldn't be strict control over colonoscopy. The patient eligibility is quite broad. So really nobody excluded. Anybody who would normally be enrolling in surveillance that gets enrolled. Enrollment would be ideally consecutive. So it's not selected enrollment. We're using a standard of care comparator. The outcomes are objective in terms of neoplasia and colonoscopy. Data is being collected from EMR data. And ideally, our trial development will also include patient partners, and we'll also have patient-reported outcomes. That's still being developed. We would use an intention to treat primary analysis method. But on the less pragmatic side, for practical reasons, the investigators would likely be academic gastroenterologists with access to coordinators, and this would, being an individual level randomization trial, would require individual patient consent. And because of the absence of data demonstrating that this intervention even works at this time, to avoid excessive crossover and contamination, I would allow the implementation to be taken out of the physician's hands and be coordinator led, which is not necessarily a very pragmatic approach. So across the pre-C wheel, sort of the stars are towards the pragmatic side for eligibility and recruitment, but sort of lie somewhere in between for most of the other spokes. And really, when I started to think about where does this trial fit in this entire spectrum, beyond being pragmatic explanatory, there is also the notion of whether we're primarily testing effectiveness or implementation. And a strategy such as this is going to depend on both the actual core effectiveness of what we're doing, but also how rigorously it's implemented in practice. Because we'll first need to prove the concept, this lies more towards the left, less towards an implementation testing strategy, which I think will have to be a later phase. And in fact, a purely pragmatic trial would not adopt any kind of specific implementation strategy. The implementation would be just in the course of routine care by physicians or nurses, or however it would normally be done in practice. In this case, we're actually fixing an implementation strategy in both arms that is a little artificial and not pragmatic. So this tends to follow more of a hybrid type 1 trial design at this phase. So primarily effectiveness, but with the non-pragmatic implementation component. And in the context of the trial, we'd like to assess potential barriers to administering the intervention in routine practice, and we'll also undertake some descriptive reporting of fidelity to the intervention in the course of this trial. But truthfully, demonstrating, testing implementation strategies would likely fit best as a future phase once the strategy is proven. So I was wrestling between whether or not this should be an individual or cluster RCT. Initially, I'd envisioned this being cluster RCT because of the potential risks of contamination, especially in terms of physicians defaulting to what they are used to doing. So the contamination, especially from a model-guided strategy backwards to a traditional strategy. But then as I started to think about it more and more, there became more and more reasons to consider this more as an individual level randomization. And really, one of the biggest limitations to cluster RCTs is the huge sample size that's required. And the sample size is heavily dependent on the number of clusters. And given the likelihood of physician participation in this trial, I don't envision there being a ton of clusters, which would make the sample size enormous. So for an individual level randomization, lower sample size, potentially lower risk of bias if practices that are randomized to certain clusters are very different from one another. We have no way of knowing the intra-cluster correlation coefficient. That data doesn't exist for this setting, so it would be a bit of guesswork. And also, individual level trials are just easily interpretable to clinicians. They're used to seeing them. And so there's some face validity to that approach. The downside to individual level randomization here would be the potential for bidirectional contamination, wherein an investigator who is now practicing both strategies across randomized patients may choose standard of care for a intervention patient and may also choose intervention for a standard of care patient for various reasons. For that reason, I elected to remove the direct decision making from physicians, so that their ask when they participate in this trial is that they refrain from decision making for routine surveillance colonoscopy, and take direction from a research support staff. But that, of course, is a non-pragmatic strategy, so it will be slightly devoid of answers about how well such a strategy will be implemented in real life practice, and that would have to be a later phase. The cluster trial, although may have less potential for bidirectional contamination, there's still potential for unidirectional contamination, wherein clusters that are randomized to a model guided strategy physicians may simply choose not to follow it and default to what they know best, thinking that there really is no difference here. So those are the pros and cons, and ultimately I sort of settled on the vision of this being an individual level randomization, but love to have some discussion around that. So the feasibility of this is going to be really dependent on having established centers with dedicated coordinators. It's going to require strong physician engagement. It's going to require strong patient engagement. I think patients often don't exactly know what we're doing in this capacity, but once they come to know that they're in a trial, they'll have all kinds of questions about, why would we want to do it this other way, and what are the risks and what are the benefits. So it's going to definitely need patient partners to help us craft this properly and to help advertise this to potential participants. Estimate a sample size between 2,000 to 3,000. That's anticipating a 2% risk difference between groups in our primary outcome, which is a high risk neoplasia within 3 years. Generally, the overall high risk neoplasia rate would be in the 2 to 3% ballpark. And so, if we were expecting a 4 versus 2%, you're looking at sort of 2,200 participants, 5 versus 3%, 3,000 participants. So I think this is the range of sample size that we'd be looking at, which across all of our practices, and we have a fairly high prevalence of IBD and established research networks across Canada for IBD trials. And so those numbers are feasible. So ultimately, why is this trial needed now? I mean, colonoscopy demands are rising in society due to immigration, aging populations that are living longer, and then also introduction of population-based screening programs such as the FIT test. IBD prevalence is also rising, largely due a longer lifespan of individuals with prevalent disease. So all of these are leading to higher colonoscopy demands, which are putting a strain on healthcare, on colonoscopy resources. And the stakes are higher in IBD because colorectal cancer-related case fatality is higher in IBD than in the general populations, so that there is a higher risk of missing lesions in this population. And colonoscopies also account for a major source of costs and resource burden in the IBD population, both on a per patient level, but also on a societal level. So streamlining this procedure towards those who need it most would be a recognizably good goal. And ultimately, yes, better stratification could prioritize those resources for patients in need and limiting unnecessary colonoscopy burden. So the plan, again, would be successful model development, which I envision it's already well underway, but it'll take probably another 1 to 2 years. In the meantime, we'll be assessing physicians and patients on their perceptions, preferences, and practices regarding neoplasia surveillance to help guide trial design, establish patient partners, and ultimately, in the process of working on grant submissions for a pilot RCT, at least 2 to 3 centers with multiple investigators to test recruitment feasibility and protocol adherence, which will then also help design the larger trial, and then ultimately try to put forth funding for a larger trial. So I think points of discussion that are of interest to me, at least, but certainly others may have other areas to explore, but whether such a trial is most suitable for individual versus cluster randomization. I alluded to the fact that there are really two outcomes of interest here: uh, the neoplasia detection capacity and the colonoscopy burden. Are we being dishonest by claiming those to be primary and secondary outcomes? Should this really be a co-primary outcome type trial? Obviously, that will inflate the sample size, but not a ton. So it's potentially doable. And then, are there more elegant approaches to studying implementation strategies within the context of this primary trial, or is this proof of principle type strategy probably a better way to go at this phase? Um, so I'd like to thank all the members of my steering committee, Dr. Dean Ferguson, the lead, Monica Tayard, Corey Goldstein's in this room, Jamie Breho, and Stuart Nichols. Jamie Breho is a implementation scientist, and Corey is a postdoc fellow working with Dr. Tayard. So thank you very much.
Perfect. Thank you very much, Sanjay, for that excellent presentation. So we'll now move on to our second panel discussion. So joining us are Dr. Tim Ramsey, who is the Associate Professor in the School of Epidemiology Public Health at the University of Ottawa, a Senior Scientist at the Ottawa Hospital Research Institute, and a Scientific Director of the Ottawa Methods Center. And joining Dr. Ramsey will be Dr. Corey Goldstein, whom you've heard from Dr. Murthy's presentation, philosopher bioethicist specializing in research ethics, and who is a CHR postdoctoral fellow and a 2025 Grimshaw Researcher in Training awardee. So our panel discussion will be followed by time for audience Q&A as well. So perhaps I'll turn things over to you, Tim, to start things off. If that's okay with you.
Sure. I guess what I wonder about in terms of like more than just the sample size required for a cluster trial, like I wonder if there really would be all that much contamination. Like I'm given that this algorithm is being applied by a coordinator, not by the doc themselves. I wonder, I mean, I know that it's, it's a standard. We always talk about that as like one of the cons of individual randomized trials, but most of the time it isn't really. So that's my feeling, is that maybe like that's being overemphasized.
Meaning that the potential for contamination may not be that high if we were to go on a cluster route, or won't be that high in the way we've designed it as a.
Well, I wonder, I suspect, and as a non-clinician, you should fact check me, but I suspect that it wouldn't be very significant in an individual randomized trial. Like in order for a doc would have to either ignore what the coordinator told him or her to do, right? Or else they would have to calculate the probability themselves rather than rely on the coordinator. I just find neither of those, like, they could ignore it anytime. They could ignore it also in a cluster trial. And in terms of calculating it themselves in their busy day-to-day, would that really happen? Like, that, I wonder.
Yeah, it's a great point. I mean, when I initially had envisioned this as a cluster trial, I had not envisioned the implementation being coordinator led. So the strategy for the cluster trial would be that this is a pragmatic implementation. Physicians are told what to do in each cluster, and we just hope they do it and see what happens at the end, with maybe some, little reminders here and there, nothing major. To make it to put this at an individual level, where now a physician has both strategies at their disposal and are seeing the effects of each strategy on a patient by patient basis, because it's not a really good way to randomize this. You can randomize, but sorry, it's not a really good way to blind this, either strategy. Then maybe they start seeing the model working in some patients and then start applying it indirectly in their standard of care arm, or vice versa. applying the model. It's predicting exactly what they would have predicted anyway, and they stopped doing it for some. So I felt like I had to sort of force the implementation in an individual level, a model, and that obviously lends itself to less certainty about how well this would be adopted in practice in the real world. But I just felt it would be the stronger approach. Prove the concept first, and then figure out how best to make it happen.
And then if I may jump in, just I have a same comment. But first, I'd like to say thank you for the very clear presentation. That was very easy to follow, and it's wonderful to see how this has progressed over the last couple of years. Um, you know, as a non-statistician, so Tim, you can feel free to jump in and correct me here. Um, it seems like not only might we be sort of overestimating the risk of contamination, individually randomized trial, which by design can handle quite a bit of contamination. I wonder if there are just additional steps you could take to mitigate those risks. So you already say you want to take the surveillance decisions away from healthcare providers, but if I understand correctly, you do permit them to sort of override the model or override the decision of the study coordinator. Um, so, so why are you letting them do that? Would you not just further protocolize in the trial?
Mm-hmm.
I guess before you do that, would you build in questions into your survey study, seeing how healthcare providers would feel if they, for instance, were not allowed to override those decisions in practice?
Yeah, I mean, doctors don't love being told what to do. Um, they so get their backs up front if they're told you have to follow this as dogma for the next 5 years.
So maybe the pitch is, oh, you no longer have to make the decision. We have some support for
Yeah,
you, and they'll help with the decision making. And
the
maybe make
truth
it
is,
seem.
yeah, I know. There are other reasons that you might that doing a colonoscopy might come up. So somebody might develop symptoms and they need a diagnostic investigation. So they're no longer be held to a surveillance scope. This is now a diagnostic scope. Patient could just ask, their sibling were just diagnosed with colon cancer, and I don't care about this trial. I really want a scope. I'm nervous, and you can't say anything about that. You can't say no. We also don't want to discount that individual from the trial. It'd be analyzed in the arm to which they were randomized, and then hopefully carry on with further. But that's also to be expected in real life. I think that in real life, even if this was implemented at its best, that's going to happen. That there's going to be ad hoc scopes being performed for a variety of reasons, risk aversion, reticence, beliefs, and other symptoms that arise. So that's why I thought it would just make more sense to give some flexibility here, but to encourage not simply making, decisions on routine surveillance in the absence of any push. And hopefully that would be a good balance.
Okay, that's really helpful. I also have just another question more about recruitment into the trial. So you sort of mentioned that you see getting informed consent is making the trial less pragmatic, but I guess I'm wondering why. How do you envision informed consent or the identification or recruitment process playing out? And why do you see that in some ways inhibiting the pragmatism of the trial?
Yeah, I think that it's probably a fallacy to think that cluster randomization eliminates the need for individual level consent. That's not the right reason to do a cluster trial. But there are situations where if a performance of a strategy is shown to be high or good, and there's a belief that it probably would work, that offering that within a cluster might be considered equivalent to standard of care. So that regardless of what arm you're in, you're getting high quality. You're getting something that's at least as good as standard of care. Is at that point, because everybody's going to be treated the same way in that center. Does that require individual level consent or not? I mean, it's murky, it may very well still require individual level consent, in which case, yes, there's really no loss of the pragmatic aspect of this. But there are some, like React and other types of trial designs where there's embedded consent implied, to participate in things in the course of routine care. This may or may not even apply to this trial. But at the most pragmatic level, I would foresee, like, an ideal pragmatic trial is not requiring individual level consent, being able to harness outcomes from admin data, really minimizing the workload to optimize efficiency. This type of trial doesn't lend itself too well to those kind of pragmatic aspects, but it may be a moot point.
Yeah, I sort of wonder about that claim. I think, if you're getting informed consent and recruitment and retention rates are quite high because you've explained the trial very clearly in a way that sort of maybe mirrors conversations that happen in routine practice. Um, your trial population is going to look a lot like your patient population. So even with consent, your eligibility domain is very pragmatic. Um, your recruitment domain very pragmatic, unless you're planning on, sort of in explanatory trials where we're trying to recruit healthy volunteers. We're going to
Yeah,
run ads in the newspaper. We're going to put up posters in the hospital. But if you're just recruiting people at the time of clinical presentation, your recruitment's 5 out of 5 pragmatic. Um, so I guess what I'm not seeing is why you can't just get informed consent without inhibiting any sort of pragmatism in your trial. It seems like that's exactly what you plan to do, given the Précis model that you showed. Even with consent, it seems very pragmatic. Um,
yeah. I guess I may just be um, amplifying, like, this component of sort of efficiency in doing the trial. Like, the consent discussion is a major time consuming aspect of a trial, especially something as complex as this. Um, in terms of whether or not it would influence, participation, and you can foresee situations where somebody is used to getting an annual colonoscopy. It's always been told they need that, and then a model predicts actually they don't need a colonoscopy at all for 5 years, and they're just not okay with that. And so, by having that informed discussion, they're not going to participate. And there may be other
well,
scenarios.
we wouldn't tell them at the time of recruitment that they're only going to get it in 5 years. I mean, you don't know that
No,
until
no,
they're
but they could.
participating in the trial. And clinicians can always override the model. So if a patient tells their clinician, look, I'm not comfortable with waiting 5 years, they could still make that decision. But that comes after recruitment,
Yeah,
right?
you of course couldn't tell them what the prediction would be, but they would have to at least know that the idea would be to follow a model guided strategy, which could mean deferral of colonoscopy beyond what you're used to.
Mhm.
And are they comfortable with that or not? Their patients, like, when they learn about the ins and outs of studies, and even when you just bring the notion of research to them, their backs go up against the wall very quickly. So on the ground, I can tell you, like, unless it's the simplest of questions where there's clearly no risk, there are lots of people who refuse participating in research. They just fear what the unknown. They don't know what they don't know. And so if if a trial existed such that individual level consent was waived, that would obviously, to me, would improve participation because everybody's participating by default. But I don't think there's a way to get around that in this trial. So um, that part of thing is probably as pragmatic as we can make it at this in this way. But thanks for that. That was some good points.
Oh, thanks very much. And while we sort of open things up, perhaps to audience members as well, I wanted to just take the I guess, the moderator's prerogative and ask the question of you, Sanjay. So in the sample size calculations, you mentioned about a 2% difference in terms of neoplasia detection rates. Um, I guess sort of what I'm wondering is, because I feel like, one of your questions was about sort of co-primary endpoints. And so what I'm curious about is the issue that cancers are being missed, or is the issue that colonoscopy is being overdone? And if it's more the latter, how confident are we that we're going to get a 2%, like a 50% essentially, reduction or improvement, I guess, in neoplasia detection rate, by sort of spacing things out? And related to that, is it possible that, that also grade of the tumor may be more advanced? So even though the neoplasia detection rate may be the same, the cancer is more advanced at the time of detection. Just curious on your thoughts on that.
Yeah, they're good questions, and they partly stem, like the rationale here partly stems from the balance between science and practicalities. In reality, um, probably the more likely outcome that we're going to see is a reduction in colonoscopy burden when we apply this. But a lot of physicians won't care about that. Then that's the bottom line, right? Because their training teaches them to improve health outcomes at all costs. And so the colonoscopy reduction argument is largely a cost argument, right? And that's important for society, it's important. But to convince peers to participate and to convince peers to practice this kind of a thing, there would probably have to be more in it than just that. And that's not to say that missed cancers and missed high risk lesions isn't a thing. It certainly is a bit of a thing because we do see cancers arising in the course of routine surveillance in this population, which ideally shouldn't have happened because they're being surveilled. And people definitely like clinicians definitely feel an importance of identifying precursor lesions. That is, our entire colonoscopy cancer screening paradigm is built on that, identifying precursor lesions and removing. So, I do truly believe that incorporating other variables, many others potentially that are not overlooked right now, can improve our ability to identify the bad players. And because that's probably what's going to resonate most with clinicians, I feel compelled that needs to be the primary outcome here. And the colonoscopy burden issue I've made as an important secondary outcome, more of a health systems outcome. You could argue it should be a co-primary endpoint where either or, but clinicians have an amazing way of believing a pre-specified secondary outcome, even if the primary outcome fails. So there is this sort of opportunity where you define a primary outcome and maybe it fails, but a key secondary outcome shows improvement or success, even not necessarily you haven't modeled your power calculation over it, but let's just it shows a massive difference between groups. That will still meet the sniff test for many individuals, as far as if they believe that reducing colonoscopy is an important aim, they will not just deem this a failed trial or a negative trial. They will value that secondary outcome as well. So those are the sort of practical rationales built into why I kind of designed it this way. Obviously, from a pure science perspective, you could argue many things.
Perfect. Thanks, Sanjay. And I see, Tim, you have your hand up.
Oh, you're muted.
Yeah, this is a really interesting problem. Sanjay and I have had extensive discussions about this. So it's not really a question for Sanjay. It's just more of a discussion point. This is sort of not exactly a standard trial scenario because you really have two competing things going on, which is the colonoscopy burden and the neoplasia detection rate. And it's kind of impossible to define a clear decision criterion that will tell you whether this new modality is better. You could imagine multiple scenarios. Like, so you could imagine that because you're identifying very high risk people, maybe you identify more neoplasias. You could imagine in which case, no matter what happens to the colonoscopy burden, you would say this is a good thing. You could imagine that you significantly reduce the colonoscopy burden and have no effect on neoplasia rate, in which case many people would probably still say this is a good thing. But you could even imagine that you significantly impact the colonoscopy burden and you have a slight decrease in neoplasia rate, but it's small, and people might still think that this is a good thing. So there isn't really kind of a clear, mathematical equation that says as long as this happens, we conclude a success. And there's no real. I feel like the answer to this is that what we're talking about is kind of a non-standard scenario for a trial, where we really do need randomized evidence to convince people. So we do need a trial, but in a sense, what we're talking about really is more of a randomized observational study. And what we're going to get out of the trial is we're going to get hopefully the goal is to get a really good estimate of the relative neoplasia discovery rate and a really good estimate of the reduction in colonoscopy burden. And then different people will make their own decisions about how convincing that is. Yeah. So coming up with a random, like the primary outcome, we went back and forth. I mean, Sanjay, I don't know if this corresponds to your recollection, but I feel like we went back and forth a few times talking about it, and we never got to a point where we felt like 100% confident that this was the best thing.
Yeah. Yeah, that's a great summary. I agree completely. Like there could be many different outcomes to this that all are important in some way. And we need something to hang our hat on for a sample size calculation. This is simple, and would actually hold water with people, so I picked it. But you could certainly have other primary outcomes that would be important.
And I'm curious, Sanjay, I know you're mentioning there will be plans for surveys and so on. Is there, in the situation where Tim mentioned where there may be a trade-off between reduction in colonoscopy burden, of course, from a cost perspective, but maybe, one could potentially argue from a perforation risk perspective and so on as well. There may be a trade-off in terms of lower neoplasia detection rates or, more advanced, neoplastic lesions at the time of detection. Do you think it would be feasible to get sort of a threshold of that trade-off to inform maybe a non-inferiority design that can then be converted to a superiority design later on, if it's shown to be non-inferior in terms of margin? Just curious.
Yeah. It's a very interesting thought. There are examples of trials in our IBD space where there's a sequential endpoint of non-inferiority on one thing, and if that's met, superiority on the second thing. And that's kind of what you're alluding to here. Like if we were to design this a different way, would we state that really reduction in colonoscopy burden is the key, and we will accept a certain threshold of non-inferiority on neoplasia detection in order to realize that. I think that it's a smart and elegant approach, but I think that it would have trouble passing the sniff test for day-to-day practice because gastroenterologists like doing colonoscopies. They get paid to do colonoscopies. And simply showing a reduction in colonoscopy burden without some other advantage to it is not going to really hold on. It's not going to lead to an immediate policy change of any kind. It's too small of a population. And it's not going to, I don't believe that would strongly influence people's practices. If that was all that was shown, they would want to pick out the bad players at all costs. And, Um, so I think for that reason, I probably feel more comfortable at least arguing that we're trying to see a benefit for neoplasia detection. And in the wash, if that doesn't happen and we happen to see a reduction in colonoscopy burden, well, then we can make all kinds of post hoc arguments that, okay, well, the actual number of colonoscopies saved per neoplasia missed is like thousands and thousands. And then maybe people come up with their own sort of decision making as to what they think is relevant or not. But I think upfront to convince clinicians that that would be enough, that we're willing to accept a reduction in neoplasia detection in order to reduce colonoscopies, that sounds like it's dead in the water to me.
Okay.
Sad, isn't
No, that
it?
makes sense. No, it's obviously interesting and important to get that pragmatic, practical considerations, right, for implementation. So thank you, Sanjay.
Well, there's no
Um,
gastroenterologists in the crowd who are offended.
All right, well, fantastic. So, perhaps, if there's any other questions from those who are participating online, feel free to, they can be certainly put into the chat or can be directed, I'm sure, to the Pragmatic Trials training program, and I'm sure they'll be able to forward them to Sanjay. So perhaps at this point, I'll just take the time to thank our speakers, panelists, and participants for a really thoughtful and engaging day. I thought, the combination of sort of the disciplines with Dr. Malavankar's a topic related to ophthalmology, and then now Dr. Murthy's topic related to gastroenterology was quite fascinating and I think quite complementary and with different sort of designs. And I really want to thank everyone for their participation today. We look forward to seeing you tomorrow. And so day two is tomorrow at 11 a.m. Eastern Standard Time for presentations by Dr. Calvin Ke and Dr. Manesh Nagappa. So look out for the agenda for additional details. Oh, sorry. Now we have a question from Amit. Is there any concern that neoplasia detection is a surrogate outcome versus colorectal cancer mortality?
Yeah, absolutely. There's a lot of concern, but that is, for better or for worse, the standard, because powering a study to show differences in colon cancer or colon cancer related death is just almost it's just not feasible. So there are almost no studies in the IBD space that use that as the outcome. It would be the ideal outcome. Colon cancer related death is the ideal outcome, but we just can't get studies off the ground with that kind of so that also is a little bit of a less pragmatic component about this in terms of what's important to patients. I think patients care about neoplasia, they care more about death. But this is sort of a balance.
Fantastic. Um, Great. So, well, thank you very much, everybody. And so have a wonderful rest of the day. And obviously, there'll be more to come tomorrow. And once again, please join me in giving me a round of applause to Dr. Murthy and Dr. Ramsey and Dr. Goldstein for a wonderful afternoon. All right.
Thanks.
Thanks, everybody.
Okay.
Have a great day.